Hello, I'm Betty Keller, Chair of the Privatization Study Committee in the League of Women Voters of Vermont. I very much appreciate your attention, as I'm hoping that we can have enough delegates understand the reason for our privatization study position, our privatization position, and support it so that we can get it on the agenda at the National Convention and then vote to adopt it at the business meeting. So thank you for your time. Vermont is a small state. We have only about 130 members, so we're all at large. There are no local leagues. The state league handles all things Vermont. So this was an enormous project for us, but we were passionate about its importance. As you may already know, the National League of Women Voters has a healthcare position as well as a privatization position. You may also know that while following League of Women Voters policy, local leagues can act on adopted local, state, and national positions. State leagues can act on adopted state and national positions. Leagues can educate about positions and issues, but coordination is required to advocate for certain legislation. So local leagues must coordinate with the state league to act on state and federal issues, and both local and state leagues must coordinate with LWVUS to act on federal issues. To act on the federal level, state and local leagues must notify and coordinate with the national office through the Federal Action Request Form. Vermont leagues and their elected officials have had a history of advocacy for single-payer healthcare, and the League of Women Voters of Vermont has typically received approval for the Federal Action Request Form when they've submitted it. In September of 2022, League of Women Voters of Vermont was surprised that League of Women Voters did not approve our Federal Action Request Form to advocate against the direct contracting entity program that was privatizing Medicare, which later became the ACO REACH program. We had fully expected the League of Women Voters would support protecting taxpayer dollars from being wasted and protect Medicare from having funds used for profit instead of healthcare, draining the Medicare Trust Fund at an unsustainable rate. These programs affect seniors who specifically chose traditional Medicare instead of Medicare Advantage because they did not want to be restricted to closed networks of doctors and hospitals and deal with prior authorizations and unnecessary denials and delays of care. We had on our Federal Action Request Form listed the healthcare position as the appropriate basis for advocacy, figuring that since the position supported expanding Medicare to a single-payer system, then it would support protecting the Medicare that we currently have. The response from LWVUS was that this was the wrong position to consider for this advocacy, and the privatization position was actually the appropriate one to apply. So that is because the representative government section has to do with how our elected representatives choose to spend the money that we've entrusted to their management. However, they also said that this privatization position did not support this particular advocacy for two reasons. Healthcare is not listed as one of the common goods, which should be protected from privatization in our position. And although the privatization position lists criteria to meet before moving a common good from the public to the private sector, and it said that there should be a process in place for holding a private entity accountable if it does not continue to meet those criteria, it did not actually provide a basis for advocacy for deprivatizing. It didn't say what to do to make it be accountable. This was shocking to us. If you look at the meeting basic human needs position, healthcare is clearly listed as a basic human need for which our government should ensure the most vulnerable people have access. And if you look at the privatization position, you could infer that a process for accountability would be to take the good or service back into the public domain. However, because the positions could be interpreted differently by different people, we needed clarity. We decided we needed to create our own state position that could allow us to at least protect our own healthcare infrastructure within the state. Two other issues were closely related. Health care policy is extraordinarily complicated, and LWVUS did not have staff that felt comfortable trying to assess the different programs and bills. In addition, LWVOS said that they didn't have the bandwidth to expand their focus. They really wanted to keep the focus of national staff on protecting our democracy in the areas where they do have expertise. So now I would like to share my screen and we'll go through our presentation now. So we're going to be speaking tonight about 4 things. I'll give you an introduction to concurrence. We'll talk about what's in the Vermont update, how the update would benefit you and your league, and what would Vermont and the League of Women Voters Health Care Reform Interest Group appreciate from you. A quick introduction to League of Women Voters and concurrence. What is a league position? A position is a policy statement formally adopted after rigorous study, reaching consensus on language, and adopted by vote of the membership. It guides advocacy to oppose or support legislation or regulation. It does not require advocacy, but having it allows advocacy. The League of Women Voters US publishes impact on issues with updated policies every 2 years after convention. So what does concurrence mean? To adopt it by concurrence. When a league adopts a position that was created and adopted by another league after that league study, that process is called concurrence, and they don't need to do any additional study. Similarly, if the national organization votes by 2/3 to adopt a league's position, a local or a state league's position by concurrence, it only requires a 2/3 vote by members and it does not require further study. Does this happen very often? Well, yes. In 2022, at our last convention, there were 2 proposals for concurrence that were recommended: the New York Health Care Update and the California Criminal Justice Update. And there was a not recommended one, the Connecticut Digital Equity proposal. And those 3 were all adopted at our biennial convention. What does the League of Women Voters of Vermont position add? The first thing we looked at is healthcare a public good or a common good? And why should it be one of the services listed in the position? So in the national position, it talks about the need to preserve the common good, protect national or local security, meet the needs of the most vulnerable members of society. And those are all things that are important, for which healthcare is important: to preserve the good of the population in general, to keep people healthy so that they can provide services to each other, take care of each other, keep the economy going, and to protect us through having healthy people to provide law enforcement and military protection. And it meets the needs of the most vulnerable members of society who otherwise would not be able to access healthcare. And as I believe I already said, the meeting basic human needs is another position that the League has, and it very specifically does list healthcare as one of those basic needs for which the government should provide assistance to those unable to obtain it on their own. The list that is in the privatization position includes public safety, public health, education, transportation, environmental protection, and programs that protect and provide basic human needs. So ideally, we would just like to see healthcare inserted right after public health, or right before or after. And if that is not possible, then we are fine with having it listed afterward, much as the position for behavioral health was added at the end of the healthcare position when that was approved by concurrence a number of years ago. So additional reasons that healthcare should be one of those services is that free market principles are not appropriate to healthcare. We have already decided that we don't want to ration healthcare by wealth. We've already decided that hospitals should not be able to turn away people who come to them with critical needs just because they don't have an insurance card, and that they are not, the hospital cannot send them off on an ambulance to a different hospital just because they can't pay. In addition, we have approved that the Affordable Care Act requires that everybody purchase health insurance. And because not everybody can afford to, we also provided the opportunity within the bill for states to choose to expand Medicaid and get assistance with subsidies for those who did not meet the stricter criteria for Medicaid. So another reason is that when something is for profit, there is a fiduciary responsibility to the shareholders to provide them with a return on their investment. So that is their purpose, their goal. While we would rather that doctors had a fiduciary responsibility to provide care for their patients, and it isn't a good mix to have the doctor torn between having an employer that's for profit while trying to also provide good care. So profiteering, in our study, we decided that profiteering was not appropriate in healthcare. While we were studying it, we determined that healthcare does not follow free market principles. There's quite a list of principles, and quite a few of them it doesn't follow. Patients are not consumers, and providers are not sellers. And in a typical free market picture, you have a supply-demand curve, and the patients, those who are demanding the services, need to have perfect information. They need to have access to many choices so that they can choose between them. And the providers, the sellers, have to have easy entry into the market so that there can be a lot of competition to provide good choices for those consumers. Patients need to know what the outcome would be of what they're buying or how much it would cost, and they would need to have choice. In the circumstance of healthcare, obtaining healthcare is actually something that is more of a coercion than a choice. If you have appendicitis, you don't have a choice. You can either choose to not get care and you could die, or you need to get the healthcare that you need. So that doesn't really fit in the typical supply-demand circumstance. And you never want two appendectomies, right? And if you don't have diabetes and your blood sugar is fine, you never want insulin, no matter how cheap it is. So the supply and demand curves just don't work. Whereas typically, if the price goes up, fewer people buy it, and if the price goes down, more people get it. Well, more people aren't going to get it if they don't need it. What else does the LWV VT update change? Beyond deciding that it was indeed a public good, we looked at the accountability and looked at the criteria that's in the current US position. And looking it over, we felt that the current position offers robust criteria for determining whether privatization is warranted and how privatized services might be regulated. But it didn't offer recourse for failure to meet those criteria. So as we created our position, we went through those criteria to determine, well, which of them apply. And pretty much they all made sense for determining. It depends on the actual service exactly and where you are. So there, not everything fits every criteria. But generally, going through those criteria was a good process for determining whether the product is doing well in the private sector or whether it should be deprivatized. Is privatization too urgent to wait for a national study? Like members of the Vermont Privatization Study Committee and members of the network of members from the National Legal Women Voters Health Care Reform Interest Group, You have likely been seeing increasing numbers of headlines about problems with our healthcare system. Many of these report the problems with privatizing Medicare, billions of tax dollars going to corporate products and wasteful administration, but also hundreds of millions of billions siphoned off to fraud and overbilling, with few fines and few consequences. That is a federal issue. The following slides will sample headlines about privatized healthcare services that can be addressed by state and local legislators and regulators. As important as federal action is, local and state action may be even more important to educate our communities and to empower states to take action and prove the value of public control of services that serve the common good. I'm going to click through these fairly rapidly with a few comments to give you a sense of how many communities are affected and how many different ways. If you have questions about specific areas, I'll refer you to our study report when we get it done, which may not list these exact headlines, but does engage with all these issues. First, let's look at how privatization is driving hospital closings and/or the closing of critical departments like ICUs and maternity care. When local hospitals are purchased by corporations and merged into larger chains, which is what has happened to most of our hospitals across the country, they too often become at risk. Sometimes corporate owners see it as a less profitable branch, as they might a less profitable storefront, and proceed to strip its assets. This might mean selling out their land, and then the hospital must lease it back at a higher price, or firing staff to cut labor costs, or eliminating departments with higher labor costs, like maternity, pediatrics, behavioral units, especially substance abuse treatment. When this is an example with Hahnemann Hospital in Philadelphia, when they closed 550 medical students per year lost at teaching hospital, 2,000 physicians, nurses, and staff lost their jobs. Needless to say, the real estate it sat on was extremely valuable to those who could develop it, just like the famed St. Vincent's in New York City, in the heart of Greenwich Village, where the land sold for $240 million, and the realtor built 200 individual condos, some of which sold for $20 million each. The same thing happens to rural hospitals. Hundreds have closed in the past 2 decades. Hundreds more are at extreme risk. This is from the U.S. News and World Report. This is from Kaiser Family Foundation News. From NPR, hospitals in debt often have no option but to accept the highest bid. When private equity and others buy cheap, fire all employees, and make millions from asset stripping, and too often leave the local community with no health care, the loss of a major employer and the loss of local physicians and nurses who must relocate to find work. We hear that these hospitals are financially unviable, but private equity purchases are accelerating. This shows the 3,143 counties in the US. The gray blocks are counties with no hospitals. The orange blocks have no ICUs. So there may be a hospital, but no ICU. The blue counties do have ICUs. Note the areas where people need to drive through multiple counties to get to an ICU. From the Center for Medicare and Medicaid Services, a page showing the crisis in maternity care across the country. From the Washington Post, in rural areas, loss of maternity care helps drive the U.S. maternal mortality rate. Over the past 20 years, more than 180 developed countries have halved their maternal deaths. They have half as many maternal deaths as they did 20 years ago. In the United States, in that period, the rate of death has doubled. So we're going in the opposite direction. In the 8 states colored purple, over 2/3 of their rural hospitals have no maternity care, which usually means that OBGYN practices and nurses have also relocated. The red means that between half and 2/3 have no maternity care. That's 20 states. You'll see that little picture of Vermont is green. So it's one of the 5 states where 75% of rural hospitals do provide such care, but our services are threatened. Not just the Washington Post and USA Today, but also the think tank Roosevelt Institute has studied how financialization and privatization affect maternity care and maternal mortality. Does this map from the March of Dimes shock you? The dark blue has no hospitals or birth centers in the whole county, 1,775 counties of our 3,100. The lighter blue has one hospital or birthing center in the county. That's 903 counties out of 3,100. This adds up to 85% of the counties across the United States. The pale blue, 2 to 4 hospitals or birthing centers in about 1 out of 10 counties. And the palest, only 91 counties out of 3,100 have 5 or more places for women to give birth. Privatization and private equity increase the cost of healthcare. You'd think, oh, well, private, it'll be more efficient, right? They'll run it like a business. No, it increases the cost. When private equity buys physician practices, the cost of patients rises 20%, even though physicians are often required by contract to see more patients for shorter amounts of time. This time requirement is a concern that lower quality healthcare will be the result. Monopolization, as we all know, means eliminating competition. It's the opposite of the free market, when PE, private equity, and healthcare has repeatedly sought to create. In studying hospitals that private equity has taken over, 5% drop in staff, particularly higher skilled, more expensive staff, to increase the profits going to investors. Almost a third of the lowest performing hospices are owned by for-profit corporations versus 1/8 by nonprofit corporations, although many of those are buried inside multi-layer corporate owners, some of which have for-profit entities as the ultimate owners and investors. Private equity has also found huge profits in home care. This doesn't mean they pay home care workers more than minimum wage. Indeed, they too often engage in serious wage theft of these poor and often immigrant women of color. But it does mean that they seek significant reimbursement from public funding for fewer visits than claimed and higher skilled staff than provided. Privatization and the increasing reduction in redundancy sees empty hospital beds as wasteful. In 1975, the US had almost 1.5 million beds. In 2022, there were only about 900,000 beds. New York has closed 20,000 beds since 2000, making it almost impossible to separate COVID patients from those with heart attacks, strokes, major trauma, and other health emergencies. Hospice care, to help those diagnosed with a terminal illness and likely to die within 6 months and paid by taxpayer funds, should not pay for patients that are not certified as terminal or patients that are dead, should not pay for services that don't happen, should not pay for staff who are not certified to provide the service. But private entities, including private equity, are getting reimbursed with taxpayer funds and making huge profits, causing more for-profit entities to enter the market. Many of you have heard of Physicians for National Health Program, that's PNHP. They have a report on their website detailing how much overcharging is happening through Medicare Advantage programs. Read their estimate of up to $140 billion per year. While I'm not concentrating on the opportunity for opposing privatization of Medicare in this presentation, be assured that private equity and other for-profit players are targeting federal tax dollars as we speak. So that website is pnhp.org. And this is a QR code. If you want to pause your recording, if you are watching a recording, then you could pull out your phone and aim the camera at that, and then there'll be a little place you can push a button to take a picture of that and go to the website. Harvard Medical School concludes that private equity-owned hospitals have alarming rates of complications relative to nonprofit and public hospitals. In case you've ever wondered, VA hospitals have among the lowest complication rates of any hospitals in the country, and the VA is publicly owned and managed. Among the complications in for-profit hospitals based on Medicare data, increased readmission rates for every serious condition, pneumonia, joint replacement, cardiac, etc. So if you take a look at this slide, all those red bars are the for-profit hospitals. The yellow is the nonprofit and the green is the public. So you'll see that all the yellow and the green, they take turns back and forth about which one does the best on avoiding hospital readmissions. But in case after case, every single one of these conditions, the for-profit does the worst. And so the way that is significant is that if you can go to the hospital and maybe for some reason or other you do end up having to be readmitted within 30 days. However, when you look at the grand scheme of things, those places that have more readmissions, typically the things that contribute can be they didn't get the diagnosis right the first time, they discharged them too fast, they didn't make sure that they had adequate services to help them do the discharge planning that they needed to do, the discharge care that they needed. So if you don't have all these things together, then that can contribute to having a higher likelihood of being readmitted to the hospital. Privatization also harms providers. For those of you who remember visits to physicians where they examined you rather than staring at their computers and insisting you answer repetitive questions, not particularly relevant to why you are sitting there in a hospital gown, American physicians spend about twice as much time as non-US physicians because our electronic health records are principally around billing codes, not health. So if you look at this picture, the beige columns are the non-US health system doctors, and then the green is the US health system. And so they spend doctors in other countries, developed countries, spend half the time that we do. And some of that is on the coding and trying to accommodate filling in all the blanks to try to help the for-profit entities get higher reimbursement by exaggerating how sick people are and what's being taken care of. And part of it is from the time you need to spend with dealing with prior authorizations and then with denials for care that was provided, appealing processes, etc. Physicians, nurses in their offices also spend inordinate amounts of time appealing denials, particularly when the treatment, lab test, or prescription is required for this particular physician. But denials cut costs for insurers, but keeping those denials helps add to the profit that they make. Wage theft means the time spent before and after one's shift for doctors and nurses, uncompensated time for recording the care you gave and how the patient responded, checking lab and x-ray results, making appeals to denials, seeking discounts for needed drugs. From Johns Hopkins University, having too few staff per patient, shortened times per patient care, emphasis on efficiency over quality, decision-making by less experienced or less credentialed staff, burnout among providers, all are contributing to increases in medical errors, now estimated to be the third leading cause of death in the US. In our study report, we discuss fiduciary care. Corporations owe it to investors, physicians owe it to patients. But with 70% of physicians now working for corporations, many are suffering moral injury every day. This slide is from an educational forum in October of 22, led by a researcher at Cornell School of Labor Relations who has studied private equity investment and practices for more than a decade, before the FTC began suing for private equity monopolies, such as anesthesia cartel in Texas and ER cartel. Note the expanse in private equity investments across the entire health sector, including ambulances, residential programs for troubled teens and behavioral care, hospices, dialysis, dentists, and telemedicine. We've discussed some of the areas in healthcare where leagues might choose to advocate against for-profit takeover. How else might your league choose to use this position if we adopted a convention? Well, deprivatizing, has that ever happened? Connecticut had the typical way that Medicaid was provided was that the states managed the care. They managed the billing. Doctors would send the bill and they would pay it. They would determine who was eligible for it, et cetera. Well, a while back, Connecticut was among the many states that privatized it with the promise from private companies that, oh, we'll be more efficient. we'll manage their care better, we'll make sure that they're only getting care that they actually need, and that we will coordinate care, and all these things will make costs go down. However, instead, costs continued to rise, and it was rising at such a fast rate that the state of Connecticut looked at it and said, well, under duress from some advocates, they decided to deprivatize, to bring it back from privatization into the public domain again. And they saved billions in taxpayer dollars. They improved public health significantly. You could see that the number of readmissions was going down. They slowed the rate of the cost increase, and they reduced waiting time and denials. You can find out more. There's some documents in the League of Women Voters Healthcare Reform.org website that we call that our toolkit with the National Healthcare League of Women Voters Healthcare Reform interest group. What are some other things that local and state leagues could advocate for if they chose? They could advocate regarding rural and municipal broadband, municipal water, trash pickup and disposal, energy grid, parking, prisons. If you want to know more about any of these, pick up copies of several different books. We have them listed on the website. The Privatization of Everything, How the Plunder of Public Goods Transformed America and How We Can Fight Back. Corporatizing American Healthcare, How We Lost Our Healthcare System. And These Are the Plunderers, How Private Equity Runs and Wrecks America. Currently, local and state leagues are often thwarted by not being able to oppose privatization and not being able to support deprivatization, even when common sense and evidence-based analysis makes a strong case. We need to advocate as individuals or to find other organizations that support what we want to advocate for. The league is silent. 2 years ago, part of the push to pass the digital equity position came from the need to support broadband as a public good in areas where telecom monopolies put it out of reach of rural households, small towns, and suburbs. Our digital equity position allows us to support municipal initiatives, but not to deprivatize for-profit local monopolies that are failing communities. Similarly, league members across the country want to draw back contracts from regarding water, trash, electricity, road repair, where rates keep rising, little to no investment in infrastructure is happening, and operations are not transparent because of trade secrets. Being able to foil what's exactly happening to public goods should not be taken for granted. Duty to investors usually conflicts with serving everyone equitably and economically for the long term. When the U.S. position does not include healthcare nor accountability for private actors not serving the public good, state leagues resist allowing support for any deprivatization because we don't have a position on this. Imagine what leagues could accomplish, saving states billions of taxpayer dollars year over year that could be spent on better uses than corporate profits and useless administration. Bills like these have been introduced in some states. League of Women Voters members can't advocate for these without the update. Healthcare reforms, including prohibiting new for-profit hospices, nursing homes, or hospitals, strictly regulating corporate claims to prevent for-profit and private equity purchasing existing hospitals, hospices, or nursing homes, and requiring transparency of corporate ownership. Who is the ultimate owner is too often hidden. So in our position, we clarified that healthcare is a public good. We articulated that, yes, we can advocate for deprivatization. But the other third thing that we did was in showing why healthcare can't follow free market principles, we showed why healthcare should not be for profit. And so we did not have the capacity to explore all the other areas to determine which other areas might also not respond properly to free market forces. But we did determine that healthcare should not be for profit and that it should not be in private hands unless you look at it very carefully and determine that it is in the public good despite being in private hands. So even if a healthcare service or good started off private for instance, I use the example of a private nonprofit. And then over time, it's always been private, has not been public, but over time it's not doing well financially, and they are approached by a private equity firm or similar, and we would want to prohibit that from being sold to another one and rather bring it into the public domain. Similarly, if a surgical center was proposed, had not been public before, it's a new surgical center. If they're proposing to build near a rural hospital, which might be skimming off the more lucrative part of the income in stream for this hospital, there would need to be, legal voters could assess the situation and determine whether they should advocate against getting the certificate of need for this facility. Maybe it would be in the community's interest to provide it, and maybe it wouldn't, but they could assess it, and this would give them standing to use the league's name in their advocacy if they determined that it was not in the common good to let such a purchase happen. How can you help get the Vermont Update adopted? I hope this presentation has convinced you to at least get the Vermont Update onto the agenda at convention, which will require a yes vote on Friday afternoon. If so, please pay attention to what else you might do. If this has not yet convinced you, we would really appreciate your approaching that issue with an open mind and learning more about it. So some of the things you can do, the start is to just ask questions and learn. What is it you don't understand yet? You can ask by sending an email to lwv.vt.update@gmail.com. I or one of my colleagues from across the country in this healthcare reform interest group will get back to you. Read the U.S. position and the Vermont Update. Both are on the toolkit webpage. And review the materials on the Legal Voters healthcarereform.org site. That's the toolkit. On there, we don't yet have the study report posted. We do have the frequently asked questions, pros and cons, some of the background, a lot of resources. And then other actions are to talk with your local and state league delegates. Help them understand why we need it, how we will use it, and why it matters, and why it's urgent. Excuse me. Promote attendance at an upcoming Zoom. We do have another Zoom on June 17th at 9 p.m. Eastern Time, 6 p.m. Pacific Time. Or they could attend the caucus at convention, which will be 9:30 a.m. on Friday, the 28th. And they can email, again, the email address for more information is lwv.vt.update@gmail.com. And we will be making a recording available on that website as well if somebody cannot attend the June 17th or if they're seeing this after the 17th. But I do recommend that you try to see a recording or get to that June 17th event, because there are 8 other caucuses happening at the same time. And so the more information you can gather beforehand, then you can attend one of the other caucuses as well. And there's not much time during the convention, aside from the caucus, there's not much time to be learning about it while you're there. You want to be studying these issues that you'll be voting on in advance as best you can. If you're a delegate or an observer, you can volunteer during the convention, whether you are at home participating virtually or whether you are in person. Of course, there's a lot more you can do while you are in person, but there are things virtual delegates can do as well. We do want to get a simple majority of yes votes on Friday. So a very common thing is to have quarter-page handouts at the doors on Thursday night and then on Friday for the vote for that. And we'll similarly do the same thing to try to get the 2/3 vote yes on Saturday. In addition, you can walk up to other tables, have the name of the state on the table typically, and just start talking with delegates, ask them if they know about the position, what their thoughts are, what questions they have. If you don't know the answers, that's fine. You can refer them to the website, the toolkit, or you can refer them to one of us. And you can spend a half an hour at the information table. That would be a super help. if you're there in person. For the virtual delegates, a lot of it is the help that you can provide is providing information or links into the chat. If you know your own delegates from your state, you can reach out to them, and you can suggest sources that you found useful in the chat, for instance. When it comes to the actual vote, there will be an opportunity to ask questions, and there'll be opportunities to speak on the pro and con sides. There'll be two different mics. It's really important that you keep track when you're there to know which microphone you need to stand behind. And typically we are only able to answer pro things if there's been the cons. So if there are not very many cons, we don't get much chance to explain why we support it and why it's so important. But we can also, hopefully they will also give us the opportunity to have people ask questions. So if someone asked a question about something that's a common concern, then we can have the opportunity to explain that. And if you're willing to be one of these delegates and want to know when and how you should show up, you can reach out to lwv.vt.update@gmail.com. So here is a picture of our website, the toolkit I've mentioned. You can see that on this homepage, there's a red banner across the top, and circled on my slide here, you can see where it says learn how. That's a learn how to support the privatization position. And when somebody first opens up this web page, it'll have that red banner and that little learn how button, so you can go directly to the concurrence information. Otherwise, it's a little bit hard to navigate through and find it. Because I've been on the website today, I probably won't have that banner. So I wanted to point this out to you before we share my screen. So you'll see that red banner across the top, but probably not on mine. I think it will be there the first 3 times you hit it in a session, and then it goes away. So it's not keeping on annoying you if you've already seen it. I do want to mention also about the the League of Women Voters Health Care Reform organization. It's an interest group that includes people from across the country who care about healthcare. We have the monthly meetings that we typically have on the 4th Sunday. Now, we won't be having it on the 4th Sunday of June because that people will still be on their way home from the convention, but we will be meeting again on the 4th Sunday of July, I expect. We do look at the calendar, and sometimes we have to move it, like Memorial Day weekend, we moved it to the first weekend in June instead. But that's sort of the pattern, is the 4th Sunday, 8 p.m. Eastern time by video conference on Zoom. And the information for how to join that is on the website. Also on the website is the archive. There's the current monthly newsletter and the archive of old newsletters. Put those out typically in the middle of the month to be opposite the time of the meeting. There's also a Google group you can join so that you can get emails. For instance, we sent around the link for how to attend this meeting and the 17th. So if you're on that email list, you'll get sometimes interesting articles and other times links for events, that sort of thing. So we'd love to have you join us, and you can sign up on the website. Thank you so much for your attention this evening. And so I will go ahead and give a little tour of the toolkit, but that's the bulk of the information that I wanted to share today about the concurrence. And I do hope that you will support this concurrence, that you will support it getting on the agenda, and then that you will support adopting it. And if you're not a delegate, if you could reach out to your delegate, and even if you are a delegate, please reach out to the other delegates in your league and in other leagues within your state and within other leagues where you have friends. Thank you so much.